Monday's here once more.
It's The Breakfast Show with Patty and Ray on News Talk K57.
He's so fine.
Well, you know, and it's always a good morning. It's always a good day when there is some Dulang playing on the radio. It's The Breakfast Show on News Talk K57. Ray Gibson here at Guam Regional Medical City for the grand opening broadcast. I'm going to call it the inaugural broadcast of the Guam Regional Medical City, although that doesn't mean to say that there hasn't been anything going on here. There's quite a lot of activity taking place of a construction nature, obviously, of a setup nature, but there's also been some healthcare going on around here, and with me to talk about, because they need to get the meters spinning. Here's a guy who knows a thing or two about getting the meters spinning from his utility years, and we've got a building to pay for now, so we better start bringing some people in to help us start paying the bills, right? Francis Santos, good morning.
Good morning, Ramon. Half a day, Guam. Good morning.
It's good to have you here, although I'm having a hard time being able to hear what you've got to say. Tell me a little bit about the story of how you got set up with the Guam Regional Medical City. Tell me the story of how they anointed you as their CFO.
Well, first, thanks to Margaret for actually, granting me the opportunity to join the team. But I was exiting my former company, Staywall, so I was looking for opportunities that were out there. And Margaret and I, obviously, we've had this relationship for going back to when she first started coming up here, and also because Staywall had a relationship with TMC.
Yeah.
So we kept that going, and we just met. Every time she came out, we either met there, or if I traveled to the Philippines, I would stop in and make sure that we saw each other and just touch base on a few things. So it's about December when I decided to exit Staywall, and then, one day I decided to say, hey, if you're in town, can I come meet with you?
Mm-hmm.
Sitting there talking, and I said, if I had an opportunity to join your team, what can I do for you? And she said, well, I have only one opening, and it's this title called CFO. And I said, Margaret, you got to be kidding me. I said, what about, like insurance, politics, business relations, something more up my line. But she said, no, rest assured, Francis, I don't need another accountant. I don't need another controller. I have enough of them. I have a bean counter next to me like Albert. So anyway, I want to welcome my real Indian friend on.
Albert Gurusamy sitting down to say, good morning to you, Albert. It's a pleasure to have you swinging by our makeshift studio here at the opening of Guam Regional Medical City. How you doing, my friend?
Very good. Good morning, and thank you for, first of all, broadcasting here from our lovely facility, and two, letting me sit in on this broadcast. Thank you.
All right. Well, the thrill obviously is ours. It's a nice place that you've got going on here, and there's so much to talk about. And we've just a little bit of time between you and I, between the three of us, to get going here on some of the nuts and bolts of GRMC. In fact, people are already calling and asking questions, and I'm going, I don't know. I don't work here. I just doing the broadcast. And they say, well, what about insurance? And you talked about being the insurance guy. I mean, when I start talking to my doctors about getting some kind of care or staying in a hospital, I'd like it to be GRMC. And what cards should I bring with me when I check in?
You could bring in all your cards. Actually, we are in the final phases of finalizing some of the insurance contracts that we're going to be working with on island, and so within this week, we should have that all settled, and so everybody pretty much could be able to come here for services.
The important question, though, has to do with accreditation and things like that, right? And I forget all of the different the CMHs and the joint credit and all of those kinds of things.
The two major functions in a hospital in the U.S. First and foremost is CMS, Centers of Medicare and Medicaid Services.
Okay.
So any hospital that wants to receive Medicare and Medicaid reimbursements must be CMS certified. And so we will seek that. And then the second one that we want to also get is Joint Commission. The Joint Commission accreditation is an option for hospitals to choose, and that option is really for a standard of quality. So if you are Joint Commission accredited, you're making a statement that you're following a very high level of quality service. And so what CMS has allowed now, because they have complete faith in the Joint Commission process, if you get the Joint Commission accreditation, you can seek a one survey, one inspection, one application will give you the other, but only in that circumstance that you meet the full component of a Joint Commission and any other of the CMS issues in it.
Has anybody from the Joint Commission come by and rode the elevator? Rode the escalators? They've got 15 elevators here. Don't go if you're coming by. If you're one of the folks that is on the invite list, don't go anywhere without an escort because you will get lost. This place is like it's an aircraft carrier in here.
Well, it's funny that you asked about the elevators. One of the huge elements in Joint Commission is life safety and the environment of care. And elevators play a large role in that. So, yes, they will be coming here. They will be riding the elevators. They will be inspecting the shafts, the air vents, the whole 9 yards.
Okay. I guess the point of it, of the question is, if somebody was to arrive at GRMC at some point for care, even though you don't necessarily have the Joint Commission has not come out here or the CMS has not been deemed, the idea is we're going to get it.
Yeah.
So go ahead and sign the papers.
What part of the process actually with Joint Commission and CMS is they don't come out, inspect you, and grant you a certification on day one. They want you to see patients first. You see an X number of patients, you collect the data, you go through the process, and then they come back and see that. Because they don't want to certify and accredit you on an empty shell with no history.
Where's your baseline?
Exactly.
Show me who you've been working with. So, Francie, where's the baseline? I know that the doctors here have been seeing patients. You've got clinics outside of this facility here.
So, with respect to that particular phase of it, we've opened the outpatient specialty center, so our specialty doctors have been seeing their patients here at our facility. We will now begin some phase-in on our inpatient services. So we're working closely with our docs to schedule what we call in our side of the business minor surgeries, more elective stuff that can be done, without too much problems, we hope. But that will allow us to begin to accept patients into our system. I think the big issue for us, and everybody is, you saw the big sign coming in, we're not ready for emergency services, but we will be.
Yeah.
So that takes a little bit of more planning, making sure all the doctors are on board, the right nursing staff and the right team is all put together, because we know once we open that particular section of our hospital, then we become, really a focal point out here. We know that our location, deals with the largest population out here, so that discussion actually has taken place with, the other hospitals with respect to, and I think we've decided we'll split the island pretty much north, central, south, and then we all deal accordingly with the emergencies that come our way.
Is it a question, Albert, of bringing systems online, or is there a strategy to bring the systems online until you're at 100%? Start with the easy stuff and work our way into your linear accelerator.
First and foremost, we have to have everything that needs basic provision in a hospital online. So you need to have a laboratory online. You need to have basic radiology online. Physical therapy maybe or may not, but we want to have it online. So the linear accelerator, you're absolutely correct, can come on a little bit later, and it will come on a little bit later. There's a few more hiccups to deal with it than everything else online. So for the most part in the building, I would say that from top to bottom, we have everything online. The things that come on later that we will phase in are those things that are not necessarily needed in a basic hospital for day-to-day operations.
Okay. Now, what about staffing? How are you doing on staffing? It seems to me every time I look, there's a new doctor for me to meet. There is Dr. Ramsey Chichakli, who I know has been here for a while, but I haven't met the guy yet.
Wonderful guy. He's our urologist, and he's absolutely...
And a little bit later on, I'm going to be talking with this guy, Dr. Felix.
Yes.
Yeah, handsome guy, huh?
Yeah.
Anyways, the good news is that the tag team, actually our dynamic duo of Dr. Felix and, of course, Dr. Mike will be joining you, and they'll provide us with, their side of the take. And Albert and I look at this way. We divide the clinical stuff and the operational stuff, saying you direct us from the clinical, and meaning the doctors and the nursing staff. But again, our struggle, and I think with any, this will include GMH, the struggle is to find nurses. And of course, doctors actually, that falls along that same line. So, in that respect, we continue to try to look for nurses to staff our hospital, because it's just, that's the constant call out there. Can we get more nurses to come join our hospital?
Well, in addition to the nurses, though, I mean, you seem to be doing something different around here, and among the first people that we interfaced with are technical and IT in nature. There's a whole lot of that, and a lot of it has to do with just standing up a new facility in the 21st century, A, but B, it also has to do with some advances that you guys are already taking. You've got a state-of-the-art billing system,
right,
as a matter of fact, and that's going to be reliant on not just a regular laboratory, but a computer laboratory, if you will.
I think the right word is that we want to be totally electronic to as much extent as we can, eliminate paper to the extent that we don't have to really be printing stuff, or you go to an old hospital, you would see just maybe one whole section dedicated to medical records. We want our system actually will have an electronic medical record system built in. And that in itself, Ray, was a challenge to get that system up and going. And then, of course, the other side of that is training our staff to be,
exactly,
up to par with it, not even up to par, to at least understand the complexity of the system, because it's not only the staff, more importantly, it's the doctors who need to, get used to this system and embrace the system, I think is more the operative word, to start charting and to start recording their activities, their treatment with their patients in an electronic mode. So we work closely with them, and actually the medical staff, to try to make that process as seamless and as simple as possible.
I can think of a couple of advantages to doing that. Obviously, it gets us to the billing part faster when you've got the records and they're all digital, and it's something that it's easy to put together into the final report. You send it up to the insurance companies, and you get paid. But it also makes it, I guess, that much easier to be able to make that medical information and therapy information transportable, so that a doctor somewhere else would be able to take a look at it and say, hey, listen, this is how I would consult here. This is what I would like to do, and if we're going to have surgery, then bring me in. This is one of the other things about GRMC that I am delighted about, is that there are cameras everywhere, and they can be seen by doctors other than the ones that we've got here.
Yes, and that's the real basis of electronic health records. So from the model of what's happening in the U.S., because this is not something new. This has really been the standard of practice in the U.S. for 10 years at least now. It's to not really look beyond outside of the hospital initially, but to just enhance the capacity within the hospital, so doctors seeing patients within the hospital can have at their fingertips the most current medical information from all of the diagnostic divisions within the hospital itself. And then to take it to a second step further, you can then now bring in and integrate communications with this information with providers outside of the hospital. And since GRMC is part of the Medical City network, and Medical City is moving to a new concept, which is really not a new concept. They want to standardize their operations throughout all of the countries that they serve in all of their facilities.
Sure.
So this new slogan that we have is called One TMC. So at the end of the day, medical information can be shared in our network just transparently for users, so that patients can move around from specialties to specialty centers, and that information is readily available. One of the big problems that we have in Guam right now...
It's like a business all deciding at the same time, okay, we're going to go, and this is the kind of computers, this is the kind of word processor that we're going to use, so that you can open the file, and you can open the file, and Bob on the West Coast can open the file.
Exactly. One of the big problems in Guam right now for anybody going off island for medical care is the movement of medical information. So the patient goes to the Philippines, they have to bring their medical information with them, they get seen in the Philippines, and then they have to bring that set of documents back, and that a lot of times gets lost in the shuffle, is not always currently available, and so it kind of disrupts the patient care.
It's going to be interesting to see how that rolls out, and what the changes are going to be, not necessarily for a casual hospital user like myself, but for people that have a kind of a chronic in and out. One of the more popular benchmarks that people use, and certainly one that's been used around here an awful lot in the history of our healthcare on Guam, is ratios, the number of employees per hospital bed, and so has anybody done the math on yours yet? I got a CFO over here, and guy in charge of...
There are two parts of this ratio business. You cannot, of course, if you talk ratio, the immediate assumption is, oh, you're going to use ratios on a business financial model and cut down to make money. Well, before you even can do that, you must meet certain health guideline ratios. So nursing, one of the biggest ones. Yeah. Nurse-to-patient ratios are very, very important, and they must be adhered to. Medicare and Joint Commission will look at that. Certain states in the U.S., and probably all the states, have state laws on ratio. Okay, on Guam, we don't have a state law per se, but we do follow very closely California and some of the bigger states. So on that side, we would follow a flag-bearing standard for healthcare ratio.
Yeah, we'll let Alan do.
Well, Alan would pump it.
Let's blame Alan.
Yeah, a little bit later on.
Don't do that to us.
As the broadcast continues, well, I've got one last thing for the both of you before I let you go and run and help put stuff in the bags out there like Kevin Kerrigan has been doing. A little bit later on, Alan Fontanilla is going to be on. Dr. Chichakli is going to be joining us as well. IT program manager Yolanda Mitchell is going to be in here to explain some of the science that is involved. So we got a full morning, as well as any of the guests that I might be able to horse collar from the outside. But just from the gee whiz angle here, Albert, what do you have in the building that you, as a healthcare provider for a long time on Guam, go, I can't believe we finally got one of these things? What is it that turns you on about coming to work every day?
Well, okay, for me, the real turn on to come to work today is that I consider myself really just a practitioner in the field, pretty much a bench person, and then to have had the years of experience doing what I'm doing and to be in charge of this and have 8 departments under me and facilitating this process and making me happen. Literally.
No, Albert, no.
No, I'm going to ask Francis the same question, but maybe a cleaner description. You got about 60 seconds.
I got about, well, again, Ray, we're making history. I mean, I can actually say, I was there when this new hospital opened. I tell my children and my grandchildren, hello, Cliff, good morning. And we're taking part in this, Ray. And I think from my side is that, to Margaret and the TMC people, thank you for the opportunity.
Yeah.
I mean, I was talking to Dr. Mike Cruz the other day, and I said, Mike, I mean, really, you're going to hang under your knees your thing. We built and opened a new hospital in Guam. I mean, first of all, you're a doctor. I mean, that in itself is something to be really proud of. So I said, you know what? We're here. Let's just do this. Let's move on. Despite all our struggles, we're here. We got it. We did it.
My producer says, wow, this is a really big deal. My remote guy says, this is a really big deal. I said, dude, we haven't opened a new hospital on Guam since before you were born.
Since forever since.
Yeah. I'll tell you what, it's 7 o'clock. We got to break away for the CBS News. You guys are more than welcome to come back and hang out with me.